everybody. Hello for those who've joined us early or on time, I should say. I might just give it a few more seconds to let people enter the room. Okay. It's 7 p.m. in New South Wales. All right. Okay. Well, I'll get started and then people can join us as they finish their dinners. So welcome to this talk today, which is around neurodiversity and use disorders, rewiring care. And I'd start by respectfully acknowledging Australia's First Nations peoples as the traditional owners of the land, and pay respect to their enduring connections to country through songs, stories, spirituality, and ongoing cultural practices. I'm on Gadigal land of the Eora Nation, and Bron, where are you joining us from?
I'm joining you all tonight from beautiful Bundjalung country of the Awakal people in northern New South Wales. So yeah, feeling really privileged to be in this beautiful space.
Thanks, Bron. So yeah, my name's Chris Davis. I'm the co-founder of the Clean Slate Clinic, and as of 3 weeks ago now, I am an addiction medicine specialist and also a GP. And I am very privileged to be joined by Dr. Hudson, who is also an addiction medicine specialist and a rural generalist physician. And now that is also a specialism I saw announced the other day.
Yeah, it's officially been given recognition, which is nice. Yeah.
Fantastic. Yeah, absolutely. Long overdue. So this is a Zoom webinar, as you'll already know. So everyone's in listen only mode. However, if you do want to speak, please do. You just have to raise your hand and then I will unmute you. But for any general Q&A as we go, use the Q&A function and I'll either type an answer or we'll answer it live. We'll try and answer most of them live, to be honest. You can, if you're having audio problems or visual problems, then pop that in the chat and Bree's in the background doing some admin for us. The webinar will be recorded and it will be added to the resource section of our website where there are plenty of webinars like this available for free. And if you do get to the end of this webinar, hopefully you will, then you can upload it onto your CPD software and use this as part of your own CPD. So these webinars are part of a whole raft of free resources that are available on cleanslateclinic.com, not just for GPs, but also for clients. We've also got a support person resource page as well, all for free. For those of you who don't know about Clean Slate Clinic, it is a social enterprise that myself and the two co-founders set up during COVID to enable people to access drug and alcohol treatments from rural and regional Australia or from wherever they were, given that a lot of the services were closed during COVID. And we've sort of grown from there, which has been a really exciting journey, sort of detoxing nearly 3,000 people safely and successfully in their own homes. And we're a social enterprise, and not many people are aware of what that is. We did toy with being a not-for-profit at the beginning, but one of our co-founders set up Hello Sunday Morning, which you might be aware of, which is a not-for-profit, and really found that he spent most of his time fundraising and couldn't spend his time doing the important clinical work that we needed to do. So we decided to become a social enterprise so we could become self-sufficient by earning enough money from the service that we were providing, drug and alcohol treatment, so that we didn't have to spend our time fundraising to government. And we do have government funding for a variety of PHNs who are helping us achieve our mission of serving the most vulnerable populations. But we are ideally going to become self-sufficient and start breaking even. And any future profits that we do make, we have it burnt into our mission. We've got mission lock in our constitution that at least 50% of any future profits has to be invested back into our mission, which is, as you can see on the screen, to tear down the barriers to accessing treatment for substance use disorders and to create a community to walk alongside our clients with unwavering support. Right, I'll hand you over to Bron, who will take you through the presentation, and I'll be in the background answering your Q&A. Thanks very much, Bron.
Thanks, Chris. And yeah, thank you to everybody joining us this evening. And yeah, big, I guess, extra special thanks to Chris for starting Clean Slate. Such a joy to work for this organization, to work with Clean Slate. And yeah, such a joy to work with you, Chris. So yeah, thanks for starting Clean Slate. And I guess, you know, to everybody that's joined us this evening, not only do I also want to acknowledge the traditional owners of the land, but just really acknowledge anyone in the audience tonight that has lived or living experience of addiction or neurodivergent conditions or both. You know, we know that people who walk into our primary care settings, they don't walk through the door with one neat diagnosis or fit into one nice little diagnostic box. That our patients bring these, you know, complex overlapping stories, and each patient is different with their, you know, unique way of thinking and coping and existing in the world. And yeah, tonight's session is really about addiction and neurodiversity in primary care in general practice, and how those worlds often merge, and then what we can do in primary care to care for this yeah, really important group of people in our communities. So yeah, over the next hour we're just going to look at what neurodiversity means in the context of addiction and some of the shared neurobiology and epidemiology of addiction and neurodiversity. We'll look at some specific examples around ADHD and autism, and work through some of the screening tools that can be used in general practice, and discuss some strategies for management and referral. Such a difficult space, addiction referrals, such a difficult space, finding referral spaces for our neurodiverse patients, especially ADHD. I think, again, you'd have to be living under a rock to not understand the, you know, the difficulties in actually getting a diagnosis and getting access to treatment in a timely, cost-effective, efficient way that that suits this population of patients. I think neurotypical patients struggle in that space, so in the addiction space. So adding the complexity of neurodiversity, this webinar is really all about them, and how we can support them right from the get-go of them presenting in general practice to referring on to specialist services. And we'll finish with a case study who will probably remind you of a lot of patients that you've met. So I love going through the neurobiology of addiction. Even if you've been through it 100 times, I find that there's always something new to learn or something new to know or something new to remember. So I thought we'd have a little walk down memory lane and remember our dear friend Phineas Gage, who in the early 1800s was working on the railroads in Vermont in USA, and his experience with the was it a tamping iron? Can you remember what it was? It was some kind of heavy iron rod that shot up through. I think they were blasting. Maybe a medical historian in the audience might remember this better than me, but I just remember it went up through behind
Before my time, Bron.
Before your time.
Yeah.
Yeah, it was about the same time, I think, you know, I started studying medicine. Through his cheek, behind his eye, and out through the top of his skull, as you can see there in his skull, which is actually sits in a museum in America, which is absolutely on my yeah, medical history bucket list of places to go and visit. But He amazingly survived this accident and was apparently walking and talking a few minutes after the actual accident. And what this case taught us, became known, I guess, as the initial neurobiology or neuroanatomical case, where we realized that different parts of the brain have specialized functions, and that his personality changes after this accident led to the investigation and then discovery of the different parts of the brain. And that, I guess, laid the groundwork for modern neuroscience as we know it now, and understanding the relationship between different parts of the brain and different regions of the brain having specialized functions. So thanks, Phineas. I reckon, you'd be cool to have a coffee with. So I think when we look at addiction and the way that addiction impacts these brain systems, it's not just one system or one neurocircuitry pathway that's involved in the neurobiology of addiction. We know that the reward pathway is impacted, that in many ways that reward pathway is hijacked. So that dopamine, mesolimbic dopamine system, the ventral tegmental area, going to the nucleus accumbens and then through to the prefrontal cortex. We know that system is hijacked, and that drugs that are commonly become the focus of addictions, they flood the system with dopamine, giving an incorrect signal that boosts that dopamine reward, that leads to that repetitive behavior that can then lead to physiological dependence on a substance. So that powerful reward reinforcement signal goes a little bit haywire. We know that addiction is impacted, that the learning and habit formation parts of the brain are impacted, that repeated use impacts the cues and the context that form habits, that creates craving responses. And I think we spend a lot of time at Clean Slate with our patients going through detox and in recovery, talking about cravings and how to manage these cravings, and how to overcome these habits that have been formed, or this learning that's been formed. We also that the idea of tolerance and dependence, and then that leading to withdrawal, is very much neurotransmitter driven, and the receptor sensitivity to neurotransmitters changes, and tolerance and dependence are all about those imbalances that come from repeated use of a substance that the brain is desperately trying to seek balance. And so when those substances are withdrawn, those withdrawal symptoms of anxiety, pain, tremor, and dysphoria, that nervous system hyperstimulation or hyperactivity is a result of that imbalance of those neurotransmitters. We know that there is impaired prefrontal control, so that top-down control in the prefrontal cortex, or our higher centers, the parts that help us control our impulses and decision making, and the ability to weigh up long-term consequences of our actions in addiction are impaired, and kind of explains why willpower is not enough, and that addiction, that continued use despite harm, like the thinking brain, the knowing brain knows that this is harming someone, but that it's more than willpower. And then the stress and emotional regulation, the amygdala responses, those negative emotional states of stress, anxiety, dysphoria, depression, drive relapses and drive people to use substances in the first place. And when relief from those negative emotional states is achieved, that cycle of use continues. And our understanding of these neural pathways and the neurotransmitters and the neurochemistry that underpins addiction has helped shape the modern view of addiction, or addiction as a medical condition. We know that alcohol now is a chronic relapsing brain disorder characterized by compulsive seeking and use despite harmful consequences, and that result is reflects a maladaptive neuroplasticity with the brain reward, stress, and executive functioning circuits. And the old view, the very outdated moralistic view of addiction, that we once saw it as a moral failing or a lack of discipline or a lack of willpower, and patients were stigmatized and excluded from healthcare and criminalized, well, still criminalized, but we now know that addictions are a chronic medical condition, and they're recognized by the World Health Organization and all of the major research organizations, that alcohol is a chronic relapsing disorder, brain disorder with behavioral and social components. So, and that's supported by brain imaging and the idea of or the knowledge that there is genetic vulnerability and the structural and functional brain changes that are seen on brain imaging. So yeah, addiction and addictive disorders are such common presentations in general practice. And yeah, like I said before, in primary care, we know that patients don't walk through the door with one neat diagnosis, that they bring this complex interplay of their own well-being, their own social stories, their own family histories, and that these often an overlap. And increasingly, we recognise that many of our patients who do struggle with alcohol and other drugs are also living with divergent conditions, such as all of these incredible conditions that fall underneath the neurodivergent umbrella, and often these are undiagnosed. So yeah, in previous generations, neurodivergence was frequently misunderstood or missed altogether, and today we've got a much better grasp of these neurodivergent conditions, and knowing that they're not simply disorders, but differences in how the brain processes information, focuses, and engages or interacts with the world. And I think understanding that shift is really critical, because stigma in the addiction space and stigma in this neurodivergent space, which is still, it's still very current. It still has a major impact on people's ability to find care, or even people's ability to seek out care. And when we understand the differences in all of these this spectrum, it gives us the opportunity to be able to work with patients, work in a way that suits them, rather than a way that can sometimes work against the natural flow of things. Yeah, I think in times gone by, again with addiction, like our understanding of these conditions has changed, and it used to be seen as a pathology or a disorder or something to be fixed. And the stereotypes of the naughty hyperactive boy, or the non-verbal socially detached male, as fitting in with these stereotypical views of these conditions. And often these kids were excluded from mainstream school and mainstream activities, and not given the opportunity to participate in their own way. And the stigmatizing that still actually exists today. Yeah, ADHD and autism, childhood conditions can assume to be grown out of. Yeah, has that been your experience, Chris?
Absolutely. So the stigma, when we think of stigma, we think of external stigma, society stigmatizing drug users or drinkers or neurodiverse people as different. But certainly what that last slide points out is when you've been brought up to believe that you're a naughty kid, or you're different, and people have told you that from a young age, then you get the internalized stigma and shame. So you really believe that you are bad or different or evil. And we know that that shame really correlates with use disorders, and is a form of trauma for sure.
Yeah, absolutely. That actually driving experimentation in the first place, and then the feeling of relief that comes from some substances. But you're so right that the message that used to be sent and still is sent in many respects. I find it really, when I observe kids in primary schools and kids in high schools, and you observe interactions with teachers, and you know the ones that get it, and you can tell the ones that don't, and you can physically see, and I'm sure people in the audience can connect with the fact that you can see the difference in the kids when they feel seen. We all know what it feels like to be seen and to be valued for who we are. So thankfully, our more contemporary thinking around neurodiversity is that it is you're moving to this strengths-based framework. So not seeing neurodiversity as a disorder in itself, but just a variation of the normal human, natural human variations in the way that brains develop and function. And that's not a disorder. It's not that there's something wrong. It's not something that needs to be fixed. And I think understanding that neurodivergence is something that does exist across the lifespan. It's not something that's just in childhood, and not something that's going to be outgrown. And I think too, the understanding now that a lot of the diagnostic research was done on a very particular population, mainly young boys, and that ADHD does present differently in girls, hence the increase in women that are being diagnosed now. And the older, outdated way of thinking really did under-recognize not just women, but people from diverse backgrounds, and our First Nations people as well. And part of that contemporary movement too is really appreciating the lived experience and the opportunity of peer support, and the value that peer support workers can have in the therapy space. So when you kind of look at those slides on the neurobiology of addiction, and then kind of understand the way that neurodivergent conditions present themselves, it's not difficult to see why there is such an overlap between neurodiversity and addiction. I think it's important to realize that a lot of that neurocircuitry is shared, that the reward pathways, the dopamine signaling, and that prefrontal executive control, coupled with the stress response, that overlapping means that people who are neurodivergent are much more sensitive to the reinforcing effects of substances, and then can find them more compelling as coping tools. Differences in sensory processing and communication styles can also lead to both increased vulnerabilities, as well as the flip side to that, increased strength. Coming back to that strength-based framework, even though there are vulnerabilities in neurodivergent people being more vulnerable to addiction disorders, there are also strengths in those features that can be harnessed in a way to help them move forward through that those treatment processes, and not to exclude the masking and burnout that happens, and alcohol then being used as a social lubricant or an escape or a way of self-medicating the higher rates of anxiety and depression that come with things like stigma and bullying and exclusion. And then just even looking at the way on the point of service barriers, neurodivergent people often find mainstream addiction services and medical services in general overwhelming. Loud, noisy, highly lit environments, the idea of group therapy. So just understanding that those strengths and vulnerabilities do definitely form a part in this, and difficulties with self-regulation, executive function, shared common drivers of using substances in the first place. And then those things like impulsivity and sensation seeking, which do tend to be more of a feature in our neurodivergent patients. So just a couple of statistics here. I'm just going to focus a little bit on ADHD and autism for a little bit. And these are some statistics that have held up the test of time. These are very consistently reported across the literature, that adults with ADHD are 1.8 to 2.5 times more likely to develop an alcohol use disorder. I think, I don't think it's on this slide, but adults with ADHD are 50% more likely to smoke cigarettes. 43% of individuals with ADHD have a lifetime history of alcohol use disorder. And that alcohol use disorder does tend to start earlier. Cannabis use disorder, 2.5 to 4 times increased risk, and 30% of people with a cocaine dependence met ADHD criteria. Why the link? The impulsivity and novelty seeking, coupled with that poor emotional regulation, and sometimes to the rejection sensitivity dysphoria, can drive people's use of alcohol to kind of numb those intense emotions. But then also, whether it's self-medicating for the hyperactivity, the sleep, or being able to focus, and the big swings that come with that, difficulty socializing, and then the low self-esteem, which is often driven out of that, that shame that you were talking about before, Chris.
Sure.
Yeah. People with autism spectrum disorders, 2 times higher risk of substance use disorder than the general population. And in this more recent study in 2020, there's up to 1 in 5 people in treatment for substance use disorder had autism traits that were identified. And people with these spectrum disorders are using substances to mask or cope with their social demands, reduce that sensory overload, and using substances like alcohol to manage their social anxiety in social situations, but also to help them fit in. Some repetitive behaviors we'll talk about in a little minute. Often in autism spectrum disorders, that there's that risk of developing disorders with online activities, so gaming, gambling online, which is often done in isolation in your room, not having to go out into the big wide world. You're in the safe comfort, but still allowing some kind of interaction with the outside world, which is a great thing, but just being aware of the fact that can lead to that becoming a behavioural addiction. So you cannot underestimate the value of the therapeutic relationship. And I think, I've said this before, but if a surgeon's tool of trade was their scalpel, like our tool of trade in the addiction space is our ability to relate and connect and talk and share. And, GPs, this is their, superpower, the ability to create safe, connected, trusted therapeutic spaces that are continuous. They're not a once off in time, despite the challenges of Medicare and the way that the system is really designed, or being designed to not create this. This really is the GP superpower of creating those, really lasting, solid, safe connections. And I see, my private practice, the real benefit of patients that have that relationship, that trusted, solid relationship with a GP that stands the test of time, that therapeutic relationship. The value of it cannot be underestimated, especially for this patient cohort. Screening and diagnosis in primary care, I think being alert for the cues that a patient might be neurodivergent. Using these screening tools, I think, are really important if time permits. I think when you look at that list, I don't know about you, Chris, but I often find that sometimes giving these questionnaires to people to take home and do, maybe not in the consult, or surely, as technology progresses, we'll be able to do more of these screening questionnaires, in consults, so it's not taking up, the actual consult time, but being able to collect some of this information in a way that doesn't mean that the patient's in front of you and you're having to ask all the questions. I know we do that with Clean Slate, have a lot of these screening tools done online.
Oh yeah, I mean, again, that's the beauty of general practice, isn't it? And the power of the continuity of care, that you can maybe suggest a diagnosis, or a patient will often, suggest it themselves, and you can give them some reading or, screening tools to take home, and then bring back in a week or so. Yeah, for sure, it's a big time saver.
And we know that treating ADHD reduces the risk of substance use disorders, and withholding meds increases the risk. And this is something that I come across all the time, and giving opinions, or writing letters of support for patients who are seeking treatment for ADHD. And obviously the effective medication in that space is a stimulant medication, and different psychiatrists have different, I think, thresholds for what they want in terms of abstinence from substances. But I think and I've got to be mindful of stigma there, because I think often people have ended up with a substance use disorder because of their untreated ADHD. So they have a neurodivergent condition. They've developed, whether it's an amphetamine or an alcohol or a cannabis use disorder, as a result of their neurodivergence. We know that there is that increased risk. We know that there are effective medications to treat that, but we're not going to give them to you because you've got a substance use disorder. Such a tricky space.
Yeah, and in the chat, Yvette has said that screeners for autism in adult females are frequently not sufficiently sensitive, unfortunately. And then Rebecca's replied, yes, we need to consider camouflaging alongside that.
Yeah, great. Really, really helpful comments. I'd love to hear more about it. I don't know if we can unmute anyone in the audience and hear more about that. I don't want to put anyone on the spot, but if you were willing to tell us a little bit more about that, I'd love to hear more about that.
Yeah, if anyone wants to chat, just raise your hand and then I can unmute you. Okay.
Any raised hands?
Not yet. Oh, Colin's got his hand up. Have you? Maybe let me hold on. Oh, there's 3 hands up. Sorry, that's my bad. Hold on. Yvette, I've unmuted you. Hopefully. Oh no. Bree, how do I do this?
Can you hear me now?
Oh, yes, perfect.
Wonderful.
Thanks.
Yeah, the screeners for autism, I mean, like, it's effective to have screeners because, you know, there's going to be a proportion of people that will be picked up with screeners. But unfortunately, with adult women, late diagnosed adult women, it's very difficult, I find, to have effective screeners that are going to pick up a good majority of people. I think there's, particularly with women who are getting around the perimenopause period, where they have those, you know, there's the indirect links with dopamine, with the changes with the hormones, which, you know, definitely has involvement here. I think that is grossly underestimated, and also because, I mean, the DSM at the moment it is geared not necessarily to pick up female people who have autism. So there's a lot of people who might go through even complete autism assessments and have it underestimated based upon the behavioural circumstances. I think that there are other methods of diagnosing autism from a genetic perspective, particularly with things like skin markers around the PTEN gene. I think those ones are definitely ones that really should be highlighted when it comes to more accurate assessment rather than looking at the behavioural stuff, because essentially the DSM is looking at when the environment falls over, that's when you get the diagnosis, not the people who have got might have a diagnosis of autism but don't meet that diagnostic criteria, because, you know, they might have ways of coping, and that could simply just be jumping from job to job, jumping from relationship to relationship, jumping from city to city, and those things in itself can cause a whole bunch of trauma and exacerbate these issues around substance use as a coping tool.
Yeah, thanks for that. Yeah, people do adapt, don't they? And as you say, can camouflage their symptoms very, very well as a way of surviving. Rebecca, I'll try and unmute you too. I think you might have to unmute yourself. Oh, there you go.
Okay.
Hi, Rebecca.
Can you hear me?
Yeah.
Yay. Okay. I wasn't sure. Oh, my dogs have heard me too. Quite similar to what was being spoken about there. I think in the absence of really cool diagnostic things that I hadn't heard of regarding things like the skin tests and stuff, that at least there are also things like the CAT-Q, which is specifically for camouflaging autistic traits. And a lot of women, including myself, who might only just kind of meet the threshold for some of the other autistic diagnostic measures, score insanely high on the camouflaging, because I think as well, for women of, you know, the particular generation as well, where we're seeing that late diagnosis, is you kind of had to learn how to mask and camouflage in order to get by.
Yeah, absolutely. Yeah. Thanks, Rebecca. Carl, can you you should be able to speak now, Carl.
Hi, can you hear me?
Yeah. Hi.
It's actually not Colin, sorry. So yes, thanks for this. Yeah, no, I just wanted to point out when you were talking about ASD and ADHD screening, just sharing from the UK that I personally don't. I don't think any of my colleagues really will make people do forms in front of us, but we send a web link for them to fill it in, and then it gets submitted back into the notes. Interestingly, on some practice research or evidence data that I looked at, that was one of the biggest hurdles to people, not that we'd send the links out, but the submission rate and getting it back to us was pretty poor. So it's just about being adaptive, isn't it? But I just thought I'd just share that from the UK experience.
Thanks, Colin.
Oh, incredible contributions. Thank you so much. Yvette and Rebecca. Like I'm really, they're things that I didn't know about, like being able to test skin. Like that's just fascinating to me. So yeah, thank you so much for that input. And I think it's so difficult to not get a little bit enraged, but that also might be the menopausal me, that there's just the amount of medical misogyny and the amount of tools, screening, you know, whatever it may be, that just misses, half the population. But yeah, I won't spend won't spend too much time on that right now. But thank you so much for that contribution. Yeah, and Cole, that's awesome having web links. I'm must be a little bit backward in my practice. I've still got good old-fashioned pen and paper. But coming back to what we can do to help facilitate treatment, overcome some of the barriers to care, it's all about how we're communicating, the environments that we're creating or we're providing in our treatment spaces, the way that we're communicating information, how that information is being portrayed. Is it written? Is it visual? Understanding routines. I think when it comes to timing and being on time for appointments and getting things done that need to be done, like bloods, like just understanding that those things, even though they may seem simple, can be really difficult for certain parts of the population. We will always come from a harm reduction perspective, and understanding that in the addiction space, a lot of the triggers that can come, we can identify them, and become curious around what the neurodivergent triggers are for somebody's substance use. Is it boredom? Is it sensory overload? Is it the opposite? Is it sensation seeking? Are they big emotions that have come, and does the person just need a sense check or some support around being able to put things into perspective, or to be able to see the different sides of that story. Helping our patients to create predictable routines and not penalizing them for when they miss appointments or they're late for appointments, even though that's incredibly hard. I remember when I first started out in private practice, and I realized that the making appointments and getting to appointments on time, and having especially for my opioid dependent patients, the proportion of patients that found it difficult to keep track of when their scripts are going to expire and then make appointments to facilitate them. I decided that I'd have a walk-in clinic where you didn't need to have an appointment, and 2 months later, I had no one was booking appointments, and everybody was coming for the 1.5 hours of walk-in clinic. So my attempt to be trauma informed and patient centered just completely backfired, and I had patients waiting for hours. And then I was going to get a system of like at the deli where you take a number and you come back when your buzzer was called. And then I was like, no, we're going back to appointments, and we'll just forgive people who don't show up for their appointments and try to have some kind of script tracking system. But yeah, it's I guess trying to find that balance between what works for the clinician and what works for the patients. Monitoring for those really dangerous combinations, the alcohol and benzos, that roller coaster, and stimulants and sleep deprivation can be a really dangerous combination for our neurodivergent patients. Screening and supporting co-occurring mental health for our dual diagnosis patients. Being aware that our traditional treatment approaches for our neurodivergent patients won't always work, and that we do need to adapt some of the ways that we treat and engage our patients with some modifications to suit their particular neurodivergence. And I really love the idea of peer support. There's peer workers in the addiction space and peer workers in the neurodivergent space. They're both really great developments in the last 10 years. What Chris was talking before about the internalized shame, that is really common, and these are some of the messaging that I use with my patients, that our brains are not always truth tellers, and adopting this idea of being a detective thinker and having a certain response or a certain feeling around something, inviting our patients to put on their detective hat and work out, you know, what is true, what is evident, what is the evidence to support this way that I'm thinking, what is the evidence to support that my boss hates me or that everybody in the world hates me, and what is the evidence to the contrary, that actually, you know, that people do like you, or whatever the particular issue might be. And as always, our language matters. That idea that you know, our neurodivergent patients, and indeed our addiction patients, are not broken. They're just wired differently, and using that strengths-based framework as opposed to something that needs to be fixed, or something that needs treating, or something that is, you know, is wrong, or should be different, or could be better.
As Colin's just popped in the chat, we all have a built-in confabulating narrator, which is so true, isn't it?
I know, we need to tell it to shut up sometime. This is just highlighting that, you know, the in the addiction space for all of us, but in particular some of our neurodivergent patients, that the risk of behavioural addictions are is increased as well. I have had a cohort of teenage patients lately whose parents have been concerned about their gaming and their phone use or social media use. And I find that a really tricky space, because what is the norm? What is you know, the average use? And is this something that's harmful? And I think, you know, the evidence is still building about, you know, the harms of phones and social media use in our kids, and is that an addiction, or is it consistent with peers? So I'm following, as you know, the mother of 2 older teenagers, I'm following that literature pretty closely. So let's talk about Claire. Did you want to introduce Claire, Chris?
There's a very young-looking 34-year-old woman.
I didn't know if it was just me, because like when I said to Chris, I'm not very good at ages, because, you know, I got on the bus the other day and I thought the driver was 10 years old, so I can't tell if Claire looks 21 or if she looks 34 in that picture. But yeah, let's talk about
just
it.
a sign of how old we're getting, Bron, that everyone just looks too young. So Claire presents to her GP with anxiety symptoms, including disrupted sleep, a feeling of being on edge all of the time, difficulty in concentrating or focusing on tasks. She feels irritable. She's forgetful and will forget forms, forget to pay her bills, will be late for appointments or miss them entirely. She can find it difficult to keep up with the school demands for her kids. She's got 2 kids, aged 6 and 8. And so at the end of the day, she will have a glass or 2 of wine just to wind down and quiet the noise in her mind.
I think we've all met Claire. Like, sometimes when I look at that, I'm like, was this case study based on me?
Yeah, very common. Could be any of us, couldn't it?
Yeah. So she's got a past history of asthma. She was diagnosed with postnatal depression after her first pregnancy, and she has been diagnosed with a mild alcohol use disorder in the past, and she does revert to alcohol as a coping mechanism in times of stress. She works part-time in an admin role. She struggles with deadlines and organisation. She reports tension, headaches, and feeling burnt out. She's a single parent and has shared custody of her kids, who are both currently undergoing an assessment for ADHD. What are your differential diagnoses here? Do people want to chuck them in the chat? I can't see the chat, Chris. So I have to rely on you to read out if there's anything in there.
Very quiet at the minute.
So I think it's such a broad presentation, such a familiar presentation, but then such a broad presentation, and I think other down the bottom there, perimenopause. So I think I can't remember whether it was Rebecca or Rebecca who mentioned it earlier, but that perimenopausal time when there are wild swings in estrogen, that is when in the Gen X, the Gen Y woman, that is the time when ADHD is being diagnosed. And I think that there's working out in that space is, did these symptoms exist when the person was younger, or is this a combination of just the current cluster of menopause, the sandwich generation, those increased demands of still caring for younger children or children at home whilst taking on the caring responsibilities of parents, so that increased stress while still trying to have careers and everything else that goes in that space. Or was this an undiagnosed ADHD, and it is the perimenopause that has lit the dumpster on fire in terms of all of that masking and all of that managing that had been happening for all of that person's life has now come unstuck because there's just one too many plate to spin, and it's the estrogen that's kind of brought it all to the forefront and brought it all to the point where we can get some diagnostic clarity. So
Rebecca, sorry, Bron, Rebecca mentions the fact that the children are undergoing diagnostic testing. It's quite telling given the heritability of ADHD and neurodiversity.
Yeah, agreed. I think it's, and that is actually often the diagnostic path, isn't it? My kids have been diagnosed with ADHD, and the pediatrician turned around and looked at me and said,
"That's familiar."
Yeah. And then they start investigating it for themselves, because again, often that cohort of women haven't really had a great deal of time to care for themselves, and when they actually dive or do a deep dive into that, and that those symptoms are really familiar and really ring true. Back to those screening tools, and thank you for the suggestion of the additional screening tools that aren't diagnostic but do raise suspicion. And I think what we are all challenged with at the moment is this person has garden variety bog standard ADHD, but they don't have $3,000 and to pay for an assessment. And hopefully that will change under the new commitment in New South Wales, at least, to training GPs and allowing GPs, very sensibly allowing GPs to operate in this space. I think it's such a no-brainer, and I was so thrilled with that announcement, which will hopefully create more access to treatment. But often the question we're asking ourselves is, what can we do in the meantime while we're waiting for a diagnosis? And there is so much that we can do, just in terms of that psychoeducation, normalizing, explaining and helping the person to develop those non-pharmacological or lifestyle strategies. Whilst they're waiting for some medication, you can start some non-stimulant medication. And actually, it's not on there, but it might be on is my next slide. My next slide. I hope you can all really appreciate this slide, as it was it took me a lot of time to put this together. I'm marveling at the AI experience here. So this chart was put together by ChatGPT in a total of, I don't know, less than a minute, with a few adjustments, and I have checked it. But the one that I really like here on this table is the bupropion, which is something that I is probably the medication that I've had the most success with non-stimulant medication for ADHD patients. And in fact, I've had a number of patients that I've started on bupropion. It's helping with their cigarettes, their smoking. It's helping with their mood. In fact, I've had a number of patients who have then gone off, been diagnosed with ADHD, started on stimulant medication, actually preferred how they felt on the bupropion, so they've come off the stimulant medication and on to the bupropion. I'd be keen to hear what people's experience in the audience was like.
It's interesting. They use it a lot in America, don't they? And it's the most sort of dopaminergic of all of the antidepressant class. So used in a lot of sort of behavioral conditions like Contrave. It's in Contrave. We're doing a study at St. Vincent's at the minute using bupropion and naltrexone called the NAVU trial for crystal methamphetamine use, because they've had good success with that combination in America. So yeah, it's interesting that it has that crossover with ADHD and neurodiversity, as well as those behavioral addictions. There's some really interesting things in the chat, Bron, as well.
Yeah.
So Aaron, not Colin, I knew it was you, Aaron, that's why I giggled before. Aaron says, I had a patient in clinic really similar a couple of weeks ago, similar to Claire, our case study. They called to discuss a possible premenstrual dysphoric disorder. After a long chat, I brought up the could this be ADHD ? And this patient hadn't considered that. So Aaron gave us some information and spoke to her a week later when she was in tears on the phone, saying how much she connected to it and resonated lifelong to struggles. And her symptoms have been unmasked by that perimenopausal time. Rebecca's written that medication shortages missing from the cons of methylphenidate. So there's medication shortage of Ritalin at the minute.
Yeah, there is at the moment, and in New South Wales, that's been a real pain for me because I've taken on the prescribing of, for somebody you can't, switch in New South Wales. I don't know what it's like in other states, but you can only kind of caretake the prescribing and not change, which has been a nightmare again, having to get patients back to their psychiatrist to get alternatives, because it doesn't look like that shortage is going to end anytime soon.
No, and Rebecca says that's the second time in 3 years that's happened. Colin or Aaron and Colin said that Zyban went out of favor in the UK due to side effects around mood. Yeah, so again, bupropion being used for food addiction. We've been trialing it for methamphetamine, and of course, classically as a smoking cessation tool. I think Champix had a lower side effect profile in the end. So Zyban sort of went out of favor, and it actually came off the formulary in the UK, where I was working as a GP in London, because of those the higher side effect profile when used as an antidepressant. So maybe it's just going to find its niche in behavioral conditions rather than as a pure antidepressant. Stephen Wu has asked which drug is good for insomnia. That seems like a webinar all for itself. I mean, insomnia in ADHD or neurodiversity, is that the question? Or
interestingly, I find that when patients' ADHD is treated properly with stimulant medication, their sleep improves despite being on stimulant medication, that their levels of anxiety and their sleep architecture actually improves. But I don't know the answer to that question, but we can certainly try and find out.
Yeah, so he clarifies of the medications that we're talking about on this slide, which one would be best for insomnia. And I guess without having the patient in front of you, that might be a difficult question to answer.
And I guess it would depend on the timing that people were taking it as well. I think, the longer acting medications, I'm finding patients are getting, good coverage. Because this is the other issue, right? Is that patients will talk about how many good hours they get in the day, and then the medication wears off. And in patients with, you know, some of those emotional regulation issues, then that wearing off at the end of the day can be a really difficult time with you know, big emotions at the end of the day with no medication on board. That, yeah, those times can be difficult. And again, when you're looking at cue-based triggers for alcohol relapses, at end of the day, your ADHD medication's worn off, and you get a case of the just stuff it, and that, you know, that's when relapses can happen. So yeah, being vigilant around those times, I think, is really important.
Yeah. And I mean, classically, when you have your stimulant use disorder clients and they tell you that they sleep very well, thanks very much, after they've used ice that day, and their appetite improves, that's when you instantly think, is this ADHD that they're self-medicating for?
It's diagnostic, isn't it?
I think so.
Party, I had a puff of ice and I fell asleep. Like,
yes, that's right. Exactly.
do not pass go.
Yvette also mentions that low-dose Vyvanse at 20 milligrams can be helpful for autism, stroke, ADHD in late diagnosed women as well, which I didn't know.
Yeah, excellent. Awesome. And yeah, we did a little masterclass or webinar for our Clean Slate patients on neurodivergence and addiction, which was kind of the springboard for tonight's webinar. These were the patient questions that came as a result of that, which I thought might be just useful to include at the end there, because these are from the horse's mouth. These are the questions that came from our patients in recovery from alcohol addiction in our Clean Slate program, which, you know, I actually really love for neurodivergent people because it can be delivered in any environment, and their detox and recovery environment can be completely tailored to their specific needs. And you know, working in a public detox unit as well, I'm very conscious of how difficult those spaces are for neurodivergent people. So yeah, and yeah, I think it's really great that programs like, you know, Clean Slate's home-based service to cater for the needs of our neurodivergent patients. But there's some interesting questions there from our patients.
Great. Thanks very much, Bron. Oh, carry on.
That's it. That's all. That's the last slide. Yeah, last slide. Just some resources. Look at that. I've even got you covered in the UK, Cole.
Brilliant. Thank you so much, Bron. Yvette just says, great question about the vagus nerve on the last slide. Chanting has definitely been noted to help with that. Yeah, I mean, we know that the vagus nerve innervates the back of the throat, doesn't it? So those choir sessions, your Buddhist chanting, gargling, all fantastic vagal nerve treatments, if you like. Well, yeah, thanks so much to everyone for joining us. Keep your eye out for the next Clean Slate webinar, and please treat yourself to the Clean Slate podcast series and webinar series, which are all for free, available on cleanslateclinic.com. Thanks hugely to the wonderful Bron. You're a star. We always rely on you to provide us with this great education. I really appreciate your expertise on this. And yeah, that's it. Everyone,
thanks for having me, and thanks to the audience for your participation. It's yeah, really appreciated.
Yeah, great. See ya.